So Dr. Judy Levison is a professor in the Department of Obstetrics and Gynecology at the Baylor College of Medicine in Houston, Texas. She got her MD from Tufts in Boston, did her OBGYN residency at University of Washington, and a master's in public health from the University of Texas School of Public Health in 2010. And for 20 years, up until just this past July, she led the Harris Health System Women's Program, which provides OBGYN care for women living with HIV in Houston, Texas. And as part of that, has just become an incredible leader in patient-directed care and understanding how to meet people where they are and provide them the best quality care that meets all of their goals. She's on the National Perinatal Guidelines Committee and provides constant consultation through the National Perinatal Hotline. And I'll just mention that when I first met Judy, she was giving a really beautiful talk about this topic about a year ago. And she mentioned that it was encouraging people to call the perinatal hotline and mentioned that she does it sometimes too, just to have someone else to bounce a case off of. And I just think that's so emblematic of how she can be the most expert in her field, but also so humble in approaching how to best care for patients. So it's just a real honor to have you here today. And she's going to update us on breastfeeding and chest feeding in people living with HIV.
Thank you, Eileen. I get teary. Thank you. I think that's the nicest introduction I've ever gotten.
All deserved.
So, yeah, we'll be talking today about breastfeeding, chest feeding, and people with HIV. And I hope by the end, you'll be able to state what's known about the risk of HIV transmission via breast milk with and without antiretrovirals, describe the motivations of those who want to breast and chest feed, and explain what has changed in the U.S. perinatal HIV guidelines as of January 2023. And just some caveats, I may use breastfeeding, chest feeding interchangeably. And when I say breastfeeding, please also hear chest feeding. Also, research done in the past on this topic has investigated cisgender women, so results are therefore reported on women. So first, I want to walk you through some history from the past 30 years or so. Once upon a time, prior to antiretroviral therapy, the risk of perinatal transmission was about 25%. And when I say perinatal transmission, I'm referring to mother-to-child transmission during pregnancy, labor, and delivery. Then somebody got very brave and gave zidovudine, or AZT, during pregnancy and labor, and for the infant after delivery for 6 weeks. And the transmission rate dropped 60% to 8%, which was huge. Then with ART, meaning combined therapy with 3 to 4 drugs, transmission dropped to less than 1%. And now we have evidence that with ART, and an undetectable viral load at conception, through pregnancy, and at delivery, among almost 5,500 mother-baby pairs that were studied, there were 0 transmissions, which is really huge. So what's the risk of transmission via breast milk in 2023? Before ART, the risk was about 16%, which was just too high. With ARVs, the original studies had suggested 1 to 5% transmission, but most of them did not include strict correlations with the mother's viral load. The most recent big study was the PROMISE study of promoting maternal infant survival everywhere. And there, mother-baby pairs were randomized to either maternal ART or infant nevirapine while breastfeeding. And the results in both groups were very similar, with a 0.3% transmission rate at 6 months, 0.6 at 12 months. So that's 3 per thousand, 6 per thousand at 6 and 12 months, which is significantly less than the 1 to 5% we had quoted before. And among some of those cases, there were 2 where the mother was, where the baby was diagnosed when the mother had an undetectable viral load. And that's something that we are very focused on. Like, if you have an undetectable viral load, is it safe to breastfeed? And what was interesting about these cases is here where you see the double star, that's the point where the infant was diagnosed. Over here on the left is the time of birth. On the bottom, this line is the mother's viral load. And as you can see, the mother's viral load was detectable at the time of the infant's birth. It went down afterward. And at the moment the baby was diagnosed, she had an undetectable viral load, but that's not what she had before. And then if you look on the right to the other, it's something similar, where here again, time of birth, and this is the maternal viral load, and her viral load went down after delivery, and then her baby was diagnosed many weeks later. So neither of these would meet the criteria that we are proposing in who's a good candidate for breastfeeding. So then comes the question, well, who wants to breastfeed in the US? Because up until now, we just said, will you please formula feed? And this is a composite of patients that taught me and really introduced me to why this is an issue. 32-year-old woman, originally from Nigeria, was diagnosed with HIV during her current pregnancy. During prenatal care, she communicated to her obstetrician her desire to breastfeed. She feared that not breastfeeding would raise suspicion in her community about her HIV status, because she knew that those in her community would say, well, in our culture, we breastfeed. You don't have HIV, do you? She had also heard and read so much about breast is best. And I just want to point out to you, this graphic was done by a middle schooler. There's an annual competition around World AIDS Day, where middle schoolers are invited to submit art pieces related to HIV, which means they have to study it some. And the idea is to try to reach them before they're sexually active. So these are like 11 to 13-year-olds. And this is one of my favorite drawings that was done. So this patient was referred to the local pediatric HIV specialist, who reviewed the risks of HIV transmission via breastfeeding. Patient expressed relief to discuss her concerns with a provider, and knowing she had options provided a space for her to contemplate the best decision for her situation. She opted to breastfeed for 3 months, both to prove to her community that she did not have HIV, and in response to public messages that favor breastfeeding. She remained virally suppressed on ARVs while she breastfed. Her baby was given daily nevirapine prophylaxis while breastfeeding, and we'll talk a little more about that later. And her baby remained HIV negative. And so it was a woman like this who came to me, and when this was years ago, and I said, well, you know, we recommend formula feeding. Is that an issue for you? And I had one woman where the tears just started rolling down her face. She said, well, you know, if I don't breastfeed, I'll have to move. I said, what do you mean? She said, well, if anyone suspects I might have HIV, not only will I not get invited to anyone's home ever again, but no one will allow their children to play with my child, even if my child does not have HIV. So that's how big a deal this is for many people. So one of the questions that comes up a lot is, does U equal U? So does undetectable mean untransmittable? And we know now, preconception, U equals U if a partner living with HIV is taking ART daily and has an undetectable viral load. So you can't give HIV to a sexual partner. During pregnancy, U equals U for the baby if a woman's on ART, pre-pregnancy, during pregnancy, and has an undetectable viral load at delivery. And then postpartum, and this is where we have a lot of variables, and we just are not at the point where we can say U equals U when it comes to breastfeeding, but we realize that each individual must do their own risk-benefit assessment. And one of the things that complicates this, and got some discussion at the conference where Eileen and I met, is we know that there is what's called cell-associated HIV and cell-free HIV in breast milk. The cell-free it seems to correlate with plasma viral load. So if you have an undetectable plasma viral load, you probably will not pick up any of the cell-free HIV in breast milk. But even with undetectable plasma viral load and undetectable cell-free RNA, there remains cell-associated HIV in breast milk. But whether that cell-associated HIV is infectious or as infectious as cell-free is not known. So that's still like one thing that just still hangs people up a little bit about, you know, how risky is this? So I'm going to now shift over to the guidelines and go through with you what the guidelines have said in the past and where we have landed so far. So starting in 1985, CDC came out and said, and this is before the term HIV was even being used, HTLV3, which was human T-cell lymphotropic virus, and LAV infected women should be advised against breastfeeding to avoid postnatal transmission to a child who may not yet be infected. By 2015, we had the perinatal guidelines, and this is similar. There's adult guidelines, there are pediatric guidelines, and these are all sponsored by the Department of Health and Human Services. So 2015 was the first time there was any acknowledgement that there might be people who were interested in breastfeeding. And what the guidelines said then was, in discussing the avoidance of breastfeeding as the strong standard recommendation for HIV-infected women in the United States, the panel notes that women may face social, familial, and personal pressures to breastfeed despite this recommendation, and that it is important to begin addressing possible barriers to formula feeding during the antenatal period. And it turned out that was really sort of the foot in the door, because by 2018, a section in the guidelines was allowed and started to address some of the specifics of people who want to breastfeed. But the language, as you'll hear, was still fairly negative. Breastfeeding is not recommended, underlined bold, to women living with HIV in the United States. Women who have questions about breastfeeding or who desire to breastfeed should receive patient-centered, evidence-based counseling on infant feeding options. When women with HIV choose to breastfeed, despite intensive counseling, they should be counseled to use harm reduction measures to minimize the risk of HIV transmission to their infants. So now we're going to move forward to 2023, and you don't need to see all this fine print because I'm going to go through that in a moment. But whatever is highlighted in yellow represents new guidelines and new recommendations. So you can see there were quite a few changes that have been made. But the major change is that the primary recommendation is now to support parental choice through shared decision-making rather than a specific infant feeding mode. And these are some of the things that went into the context and the evolution of the new guidelines. First, we looked at health benefits from breastfeeding. And this is the breast is best. And, this is all over every billboard all over the place. And then we had been saying to women, oh, no, you can't do that. But what we know is that for the infant, there's a lower risk of infants developing asthma, obesity, type 1 diabetes, respiratory disease, ear infections, sudden infant death syndrome, gastrointestinal infections, and necrotizing enterocolitis. For the breastfeeding parent, there's a decreased risk of hypertension, type 2 diabetes, and breast and ovarian cancers. We also had equity considerations, and that is that Black women are disproportionately affected by HIV, and people of color experience a greater burden of many health conditions that may be alleviated by breastfeeding. There were cultural considerations, environmental, social, familial, and personal pressures to consider breastfeeding, and the fear that not breastfeeding would lead to disclosure of their HIV status. So these are some of the specific items that were addressed and the wording. First, as you see on the left, and I think this is really important, for people with HIV who are not on ART and or do not have a suppressed viral loaded delivery, replacement feeding with formula or banked pasteurized donor human milk is recommended to eliminate the risk of HIV. So we're talking about people who have well-suppressed HIV on ART who are candidates for breastfeeding. So individuals with HIV on ART with a consistently suppressed viral load during pregnancy at a minimum during the 3rd trimester and at the time of delivery should be counseled on the options of formula feeding, bank donor milk, or breastfeeding. And pregnant people are told the infant feeding options that eliminate the risk of transmission are formula and pasteurized donor human milk. Fully suppressive ART during pregnancy and breastfeeding decreases breastfeeding transmission risk to less than 1%. But at least so far, we can't say 0. We also address situations where we recommend thinking about stopping or modifying breastfeeding. In the case of a detectable viral load, breastfeeding should be temporarily stopped. And we don't address really what we mean by detectable, because we certainly all have seen people with small blips where, there's a 53 or an 80, and then it goes back to normal or to undetectable. And I think we're talking really more of greater than double digits. If detectable viral load, breastfeeding should be temporarily stopped. Options include giving previously stored breast milk, pumping and flash heating, providing replacement feeding or cessation of breastfeeding, repeating the viral load, and reassessing continuation or cessation of breastfeeding. If the repeat viral load is detectable, the panels advise immediate cessation of breastfeeding. And this is one place where the guidance is more directive than the general counseling for people who are well suppressed. And this is what I said I would come back to. There's no consensus on antiretroviral prophylaxis for infants of individuals with sustained viral suppression who are breastfed. And members of the panel and clinicians all over the country represent a full spectrum of practices. So most panel members agreed on only 2 weeks of infant zidovudine, which is a change from the previous 4, which was a change from previously 6. But several panel members prefer to extend the duration to 4 to 6 weeks if someone was breastfeeding. Alternatively, some panel members recommend 6 weeks of nevirapine as recommended by WHO for breastfeeding infants at low risk of HIV transmission in resource-limited countries. And then others opt to continue nevirapine dosing throughout breastfeeding. And that's what our Houston pediatric specialists prefer to do. And that's why in the case that I presented, that is what was done. I'll also mention that there are in Canada especially, there are clinicians who have given full therapy. And also there have been, I think in Baltimore also, there have been some, one protocol has been giving full therapy for 6 weeks and then switching over to nevirapine. But we have absolutely no evidence to support any of these. And so there's some guesswork that's going into this. The other issue that has come up is the issue of intermittent mixed feeding. And when I say mixed, meaning going from breastfeeding to formula. And back in the late 1990s, there was a study prior to antiretroviral therapy being available, where it was found that if a breastfeeding parent went back and forth between, and this is also not clear, formula, maybe even giving solids to a newborn, so not a good idea, because very irritating to the immature infant gut, that there was a higher rate of transmission than with exclusive breastfeeding. So there was a big push toward exclusive breastfeeding. Do not give formula. But now for the last 20 years, we've had really good antiretroviral therapy, and no one has repeated that study. But there's sort of it has been that lingering concern of, well, maybe if we're really going to do this, maybe we just should say exclusive breastfeeding. And this is the first time where the guidelines have come out and said, if breastfeeding is chosen, exclusive breastfeeding up to 6 months of age is recommended over mixed feeding, acknowledging that there may be intermittent need to give formula. For infant weight loss, milk supply not yet established, which is probably the most common thing that we see. The mother not yet having enough stored milk. Solids should be introduced as recommended at 6 months of age, but not before. And so this also is a big change, because a few years ago, we had a few cases of moms who wanted to breastfeed. Somebody in the nursery didn't know and gave the baby formula. And then everybody was up in arms. Oh no, the baby got formula. Oh, it's over. Mother can't go back and breastfeed because that would be mixed feeding. And so we don't have to do that anymore. And if a baby needs to get formula here or there, we are saying, and she's well suppressed, that this is most likely okay. So there's a lot of new content on how to support breastfeeding and weaning, monitor parents and their infants, and manage specific situations, but a lot is based on expert opinion. There still remain many gaps in data. And so we have no studies that have systematically evaluated the risk of HIV transmission through breastfeeding when maternal ART is started before pregnancy or in the first trimester and continued through breastfeeding. We have no data to inform the appropriate frequency of viral load testing for the breastfeeding parent. Another big change is that engaging Child Protective Services or similar agencies is not an appropriate response to the infant feeding choices of an individual with HIV. And we've had many pregnant people with HIV who have reported that after expressing their interest or intention to breastfeed, their providers threatened to report them to Child Protective Services, or actually did so. And such engagements can be extremely harmful to families, can exacerbate the stigma and discrimination experienced among people with HIV, and are disproportionately applied to minoritized individuals. And I will tell you, I had heard about this in other parts of the country, and then it finally landed in Houston. A few years ago, well, actually, it's probably about 5 years ago, we started having an agreement that pregnant people would sign saying, I understand, not 100% guarantee that there couldn't be transmission. I understand I need to be taking my medication every day. I understand I need to maintain my viral load undetectable. And so there may be a dozen points. And we have each patient sign it, then OB signs it, and then we also have them have a consultation with our pediatric HIV people. And now it's been done on Zoom, which has made it easier. And they also sign the document. And so this way, somebody can come into labor and delivery and come with a document to just show, look, we've talked about this. I'm just not making this decision on the fly. And that was the intention of having the agreement. This one patient of mine called me and said, I had Child Protective Services on, actually she came in and she said to me, I had Child Protective Services on my doorstep this weekend. I said, what happened? She said, well, I went to WIC to get my supplementary food. And I said, I have HIV, I'm breastfeeding. And they said, oh, we'll have you talk to our lactation consultant. She goes and talks to the lactation person. And she says, I have HIV, I'm breastfeeding. And the lactation person's eyes got big and said, I'll have to get back to you. Okay. The next day, Child Protective Services was knocking on her door saying, we understand you have HIV and you're breastfeeding. So she went and got her agreement and she said, that's correct. But look, my doctor signed it. My baby's pediatrician signed it. And the CPS worker was a little bit stumped and said, we'll get back to you. And so after the weekend, she came in to see me and we called Child Protective Services. We found the worker and we educated her. We called WIC. We found the lactation consultant. We educated her. And, they laid off. But this could have ended very differently. And she could easily have had her child taken away from her. So we're not saying that not to engage Child Protective Services for other things, but not for HIV and breastfeeding. So the other thing that was new in the process of developing the guidelines was we integrated input from the community in ways we hadn't before. Many of you may be familiar with the WELL Project. If you're not, I recommend Googling it later. They are an advocacy organization for women with HIV. We also included input from the International Community of Women Living with HIV North America and some others. We got input from lactation specialists at CDC. And there was a new level of collaboration between the perinatal and pediatric panels, because before we would write our guidelines, they would write theirs. We each would review each other's and make a few comments, and then that was usually the end of it. But this time we developed our guidelines, and we realized also that the perinatal guidelines were addressing some of the infant prophylaxis things when we really weren't involved in that. And we with the pediatric panel, we're able to say, hey, wait a minute, why don't you do that issue and address the uncertainties about, do we need to prophylax infants? And we'll stick with the counseling prior to delivery. And so it felt like a much cleaner designation of roles. And we kept going back and forth with like every dozen versions. We would shoot it back and forth, and until we reached a point where there was consensus and people were comfortable on both sides of the aisle, the pediatric and the perinatal, with what we had come up with. And the other big step was that CDC chose to refer any queries about infant feeding to the perinatal guidelines. And up until then, they had their own recommendations. Some were dating back to the 1980s, and they were just all over the map. And it was actually a community member who pointed out to me, she said, my dream is that CDC gets up to speed. And I said, well, why? Because we have these national guidelines. And I was in my little national guidelines bubble. And she said, well, you know, where do most doctors go? They go to CDC. And I thought, oh my gosh, you are so right. When there's something I don't know that's somewhere, some intersection of public health and medicine, where do I go? I go to CDC. And I wouldn't have known about the DHHS guidelines unless I were in the midst of all, you know, working in that area. And so her words really struck a chord, and we are very grateful to CDC for what they have done. And so now there is one set of national guidelines. And then just to give you an idea about what's happening nationally, that the change in the guidelines comes at a time of increasing interest among providers across the country. This is a graph of activity on the perinatal hotline, which is run out of UCSF. And this is a 24/7 amazing service. Clinicians can call in from anywhere in the US or American territories and ask questions. It can be 3 a.m. and you just have a newly diagnosed patient with HIV in labor, and you're trying to remember, what did they say at that last lecture? And you call the hotline, and there's a real human being at the other end who is very knowledgeable and can give advice. So in 2014, less than 5% of the perinatal calls had anything to do with breast or chest feeding. In 2022, over 25%. So you can see that the interest has been rising, and that was even prior to the guidelines changing. And this is a lovely paper that was done by a group of pediatric residents at UCSF. And they were trying to understand what some of the issues were for clinicians. And so they sent a survey out to people who might be involved in maternal, fetal, infant HIV work, and had 99 physicians and clinicians respond. 42% of them had cared for someone with HIV who wanted to breastfeed. 10% of them had an institutional protocol. And I'm not saying there should be one, but it certainly was, you know, this was a statement on how everybody was kind of on their own in terms of, what do you do when somebody comes in and says they want to breastfeed? And they identified the provider discomfort. Here is the fulcrum. And on one hand, wanting to respect patient autonomy, and yet on the other, feeling very uncomfortable because this isn't the way I was taught. I'm really afraid I might be sued. I can't take care of this person. And just some of the comments, some examples of comments are, I feel the need to protect the infant and think it isn't ethical to put the infant at increased risk. Therefore, we have to this point only allowed women with stable suppressed viral loads to breastfeed their infants, which actually I would agree with, because we completely agree with the stable suppressed. Some of the providers in our small group believe that our guidelines should be liberalized. Other providers feel that we should not allow breastfeeding among women living with HIV under any circumstance. It's been difficult to get consensus. And I would not feel comfortable because there aren't specific guidelines or literature to support the care. However, I'm very interested in learning more for those who are interested in breastfeeding to be able to support that decision. So you can just feel that sort of uncertainty that was everywhere. And then patients have struggled because they haven't been getting any support. There was a lack of guidance. And this is Cece Coven, who has been one of the greatest advocates. She was not, and I say in quotes, allowed to breastfeed her first child 11 years ago. And then when she had a child about a year ago, she did choose to breastfeed. And so she's had both experiences, and she's very articulate in talking about how different the experiences were. And as she says, it's very important that we're given a choice. Like, I just need you to support what my decision is. It's not my provider's place to tell me what to do with my life or my babies. I just need you to leave the space open for discussion and choice. And she works with the Well Project. And then we're slowly getting data accumulating on breastfeeding in high resource countries, because we have not had that. I mean, some of the leaders of the African studies have said, why are you so arrogant that you won't pay attention to all the thousands of women who've been studied in Africa? But the one thing is that we haven't been able to document the really tight viral suppression in a lot of the African studies. And we have more accessibility to frequent viral loads here in North America. And so these 10 came from Johns Hopkins. So there were 3 infants who had been reported from Canada, 10 Baltimore, 8 Washington, 13 Italy, 30 from Germany. And as of yesterday, it came into online print. We have a series of 72 that we did a multi-site study that included some Canadian sites as well as multiple sites in the US. So there were a total of 13 sites, and accumulated 72, and had follow-up on the infants in about 95%, and there were no transmissions. So that will be in print from Clinical Infectious Diseases in the next coming months, but it is available online. So just some resources as we all navigate this new road. One is this is the website for the guidelines. If you go to hivinfo.nah.gov, at the top it says guidelines, and you can pick perinatal, pediatric, pediatric, adult, and adolescent, or whatever you want. And so that's where you would find the actual wording. And, and if you hear clinicians who are just unsure what to do, even after reading guidelines, there is the National Clinician Consultation Center or perinatal hotline. They also have a warm line for adult HIV. They have PrEP and PEP hotlines. They have a hepatitis hotline. They're very amazing. This is the number for the perinatal hotline. And as I said, 24/7. And there's no such thing as a stupid question for them. And as Eileen said, yep, even though I am a consultant for them, I sometimes call, just say, okay, who's available? I just, I know there's no right answer in this case, but I need somebody to talk to. And just, and then often there are ideas that we brainstorm and that come up that I hadn't thought of by myself. So if you're a clinician or you work near clinicians, put this number in your phone. I wish it existed on every labor and delivery. So we've come a long way. We've listened to the people we hope we're serving and working with, and we still have a lot to learn. And I thank you.
Well, thank you so much, Judy. That was amazing. I see a few comments in the chat, so maybe okay. I'll see if Laura Cheever or Jean Keller wants to unmute, but and then I have some questions too.
I'll just say,
sure.
go ahead, Laura. Go ahead, Jean. Okay, I'll go first. So first of all, Anna Powell wanted to be here and she apologizes. She had to go to the OR. So I'm the co-director of the Women's HIV program with her. So I don't think we've met yet, but thank you for this great presentation. And as you know, we've been doing this for many years. And one of the biggest hurdles we had to overcome was actually in our own system.
Yep.
The lawyers, the nurses, the people on L&D, and it took a while to get everybody in the same room together. And I can't even tell you how many meetings there were to put a protocol in place. But you probably know, Judy, right? So it's really important with an issue like this that everybody understands it, so that patients aren't like treated badly when they go to another provider and say, "Why are you breastfeeding?" It's like, whoa, you know. So thank you for talking about that some, but I also want to remind our group that we do have people who can answer questions for them if they have questions about their own patients. But thank you.
And that's a really good point, because when we first introduced this concept in our hospital, and this was, even prior to the guidelines even addressing this, but, I had women who I knew were going to breastfeed. If I said no, they were going to do it under the radar. And that just didn't make sense. And it just sounded unsafe. And we'd much rather people do it with support and come in for their viral loads and make sure their babies are getting what they need. And so I went to, this was our county hospital, and I went at change of shift for the residents. I went at change of shift for the nurses, but change of shift for the nurses, that's one set of nurses, but there are 50 million other, groups who might be rotating through on different days. And realized really needed, something's, a way to get this out more. And we had worked with our pediatric HIV specialists and thought, oh, we have a united front that will help, but realized we had forgotten the general pediatricians, because who's there at the time of delivery and overseeing the nursery? It's the general pediatricians. The pediatric HIV specialists don't come in till the next morning, and we had missed them. And so we got on board with in services for the docs and for the nurses. And now, as this has been picking up, there have been several people working together. Rachel Scott, who's at MedStar in Washington, D.C., Jenny McKinney, who is my colleague and successor, and I think Liz Lowenthal in Philadelphia, working on who are all the people that need to be informed. And we realize the lactation specialists need to be included. And we now have, there's a pediatrician who oversees lactation at our hospital, who now is also included in the consultation prior to delivery. So there's the OB, the pediatric HIV person, and the lactation doc. And so that everybody is on the same page. But it is a process to get everyone up to speed. Absolutely.
And the only one other comment I wanted to make, and I know my nurse who deals with this a lot more than I do is on here too, Allison, she may want to jump in. But to start this process early on, even if you're doing preconception counseling, and it should be part of the conversation early on, and then ongoing throughout the pregnancy, because women may change their mind, but also to let them know that we want to make this as a decision, be their decision, and we partner with them in the decision making.
Yeah, and I see Allison's comment. A huge help for us has been the lactation consultant on L&D. Yeah, and she also meets with our patients before delivery, and that's perfect.
Yeah, this is Laura. I just wanted to also add that we feel like, how could they have done that? That mandatory reporters are doing their job from their perspective. So it's really important just to understand why, different people's motivation to report. Some people are literally thinking this is what they're supposed to do, and they're careful about mandatory reporting, and they do it. So.
Well, and Laura, explain to me, what do you mean by mandatory reporting?
There are a bunch of people like school teachers that need to lactation, people that work in WIC, that if they're suspecting child abuse, they're supposed to report it. And so that is, a couple of people I've talked to where this has happened, the person doing it felt they were doing their job. And I'll also say that when we've discussed it, when Judy presented at the Ryan White Clinical Conference, even last December, but years ago, when I first heard her bring this up, and we had a discussion at Croy during a lunch meeting that the perinatal hotline put on, the pediatricians were up in arms. And like, okay, you're saying 1 in 1,000 chance that a kid could have HIV. Have you ever tried to, live through HIV as a child? It's a really tough thing to do. So people felt pretty passionate about it on the pediatric side, and that was still a response back in December. So I think the fact that Judy's been so artful in bringing the pediatricians along on this, and they're going to have comments in their own guidelines, has been really important to help sort of change hearts and minds of pediatric groups where they're focused on their patient, which is the baby.
Sorry.
And Kima, do you have a question?
Yeah, I just wanted to say that was a great presentation from Judy. I really appreciated it because it resonated with me. I have been a clinical HIV doctor in Africa for many years, and I realized that some of the things that you mentioned in Africa, we did them with evidence-based, because people with the guidelines we had was from the WHO, and the WHO said exclusive breastfeeding, and most women were on exclusive breastfeeding, and it helped. Evidently, people did it because they said you don't change a winning team. If you're doing something and it's going on well, why do you change it? So the controversies that we had was that we follow what we feel that is working and not what we feel that people tell us is working. So it was evidence-based, and some of the breastfeeding facts were evidence-based. And just you agree with me that a lot of things happened within that line, especially in the beginning of HIV treatment. There was a lot of not knowns. We didn't know many things, and we had to do things the way we thought would work.
Right. No, that makes sense.
Well, thank you for that. So, Judy, I just wanted to get into the weeds on one point, which I think, Allison Livingston put another really good comment in the chat, which is that infant follow-up is fine with a subset of providers in-house, but then may be challenging when you cross over into the community where people are still concerned. And so in thinking about how to address those concerns and thoughts, I just, with your experience, and, Jean and others on the call can, of course, chime in, but, we always think of the postpartum period as being this super intensely challenging period for like a million reasons, but among them, a period during which medication adherence might suffer due to sleep deprivation, new demands, like all the things that are changing. And just in thinking about the concerns from people who are more focused on risk of transmission as opposed to this sort of global, what is, because just stepping outside of the risk of transmission, like we know it's not a super high rate even in the absence of really effective therapy. So, but just thinking about how frequently you check viral loads and what your general practice is, and whether your experience is that truly is this super high risk period for non-adherence that sometimes I think we think it may be.
Yeah, no, and I think I think that's a really good point, Eileen, because there is evidence of less adherence after delivery for all the reasons you mentioned. Your life has just been turned upside down. However, there are some hypotheses that actually these women are going to be even more adherent because they don't want their babies to get HIV, and they're going to do everything possible to protect their babies. What we found was also interesting was the majority of our women who chose to breastfeed had known their diagnosis for at least 5 years, had been on ART for that long. They were experienced, and they already had a track record, and they knew what they were capable of doing. And I think that's in the 72 that we just published. And so that was kind of interesting to me. And I think we're going to see, but some people think that there'll be more adherence if you're breastfeeding. And just like, there are many people who were never adherent. I certainly saw this with adolescents until they got pregnant. And suddenly they're pregnant and it's like, whoa, undetectable. And I would have conversations with some of them just saying, this seems like it might be a little different than what you were doing before. Oh, yeah. Oh, I used to take my meds, maybe once or twice a week. Oh, yeah. No, I take it every day now. I said, well, what's different? Well, there's someone else I'm responsible for. It was like, whoa. And so I think there may be some of that we see, or I hope that's some of what we see. But yes, are there risks? There are. But I think what the community has taught us that it's not only that, like I think up until now, our world has been transmission or not. That's all that matters. And what our women have told us is, no, it's bigger than that. And we're whole people and we have communities and and so please take the whole person into account. But you're right, there's certainly, there's some pediatricians who, are probably apoplectic about the new guidelines. And, I think it's a process. And for the patients, it's hard because it depends whose office they land in. And there was one woman who contacted the Well Project just saying, I've talked with my OB throughout about breastfeeding. It seemed like it was okay. And then this pediatrician appeared on the scene and said, absolutely not. And then the OB was sort of in a quandary. And so the woman called the Well Project saying, what do I do? And we said, get your doctors to call the perinatal hotline so that they get the most up-to-date recommendations and they hear from other clinicians. And so some is, I think, educating patients to know that there are choices. And if one person is not meeting their hopes and expectations, that there may be, other clinicians they could go to.
Matthew, yeah.
Hi, Dr. Levison, thank you so much for that talk. It was fantastic. I learned a lot. Do you have experience of breastfeeding in the context of long-acting injectable ART, and whether that's sort of changed the paradigm in any way? You're laughing, so I'm assuming that this is like the 50th time today.
No. You're asking the question of the century, and you're prescient. I think maybe we'll have some answers. Well, the first question is, what about in pregnancy? And we know that probably this year we're going to start seeing pregnant women come in on the long-acting injectables, and then there's this moment of, now what do we do? And I think so far it's been, well, probably switch to orals, but then when, because this is long-acting and it's going to be there for a while. And this is complete, there's an abyss there. But we know we're going to have to face it. And it's people, I think there's been one case reported so far. And then there's some who are on injectables and they say, this is the only thing I'll do. And they're going to be the ones who really are leaders in providing knowledge, I think, because they're the ones saying, sorry, this is the only thing that's ever worked for me. I'm going to be pregnant and this is what I want to do. And I would honor that. I'm not going to admit her and force feed her, her pills. So I think those people are going to be really helpful to us. And then, I think we have so I have absolutely no evidence, but it seems like viral load is the key. So, ask again in 10 years.
Thank you so much.
Sure. When Eileen, you also mentioned about how often to check viral loads. The guidelines say every 1 to 2 months. We do it about every 2 months. And we realized that this was also another logistical thing, that in the beginning, we were just saying, well, now you're going to go back to your primary HIV doc, and we would send them a note saying, oh, by the way, she's breastfeeding, and this is what we recommend. And we kind of let go of them. And I think we now feel like, no, I think for this, we should still maintain postpartum contact as the OB care providers. And, we started this, let's see it to its conclusion. And I think that's, yeah, I think that makes more sense at least for our group.
David?
Yeah, thanks for your talk. I do pediatric and adult HIV, so do come across some of these mother-baby pairs.
Yeah.
And you mentioned in your talk about a mother who was going to breastfeed, was committed to breastfeeding in any way, and you wanted to make sure it was done as safely as possible. So as this becomes more common and it's less those kind of vanguard, perfectly adherent folks who've had HIV for 5 years and never missed a dose, as it becomes maybe more mainstream and some of the people who don't quite fit into that perfect algorithm of adherence are interested, has your program developed other protocols, or how are you supporting those women who want
Right.
to?
And I think, right. No, that's a great question. And Allison Levison, I think also, she said of our last 6 recent intakes, 4 women want to breastfeed, 2 are new diagnoses. This is very different than 5 years ago. So yes. And so that's part of why the guidelines say at a minimum of 10 weeks or 3rd trimester, basically undetectable to be a candidate. So that's the current recommendation. I mean, I don't know. Nobody knows. So, I mean, but that seemed at least to be safer than just saying, oh, you had 1 undetectable viral load, go ahead. So that's right now the recommendation.
And how do you deal with that tension between allowing someone and being a candidate and someone making an individual choice? Like, what is
And
role
people, right.
Yeah.
And I mean, we make it clear, we're going to support you, whatever you do, but we want to make sure you're making the decision with the most up-to-date information. If you've had some detectable viral loads in these last few months, but prior to delivery, you're at higher risk of transmitting to your baby. And are you willing to take that risk? And if you are, then that's, on your shoulders. But most of the time, when women get, they get that talk, they back off. They want to do what's right for their babies. And so we have not gotten pushback on that. And we may, but we had one woman who had wanted to breastfeed, and I had had the discussion with her early in pregnancy. I said, well, once you have an undetectable viral load, we'll talk about it. And she never had an undetectable viral load, so we actually never talked about it again. And she arrived in labor and delivery and announced she was going to breastfeed. This is what led to us having an agreement that people would sign. And she said to the residents, yeah, I want to breastfeed. And so they said, oh, it's Dr. Levison's patient. Oh, that's probably okay. It's like, oh no. And the next morning, somebody called me and said, did you know this Miss So-and-so is breastfeeding? And I said, no, she's, she is far from a good candidate. And they said, should we talk to her? And I said, please. And once they talked with her and just said, hey, this is why this is probably not the best idea. Because it really puts your baby at high risk, and she backed off and it was fine. So I think it's just, having the open discussions. And so far, I mean, I'm sure that, there are going to be some people are going to do what they're going to do. But they're going to do that regardless of what you tell them. And, but so far, really, most people, if they feel like they've been treated respectfully, they're very willing to listen. My experience, anyway.
Jean, did you have any other comments?
Yeah, I just also, the other point of time I think that's very important is post-delivery, making sure that women, particularly if they're breastfeeding, that they get back into care quickly. Whether it's with, for us, it's a little easier because they could see us, the GYN, actually in the Bartlett Clinic, but sometimes they go elsewhere. So making sure that message follows through, that they need to have viral loads done, and, to make sure that we're not missing anything when they leave the OBGYN world. So that would be my last comment on this.
Well, Well, thank you so much. I know we're coming up to the top of the hour, and again, many of us in the Bartlett Clinic lean heavily on Jean and Allison and all of the support we get, but it is so important that we understand how these conversations are happening, and in particular, even for the counseling you do right at diagnosis, which, feel very comfortable counseling right at diagnosis about future fertility. But if someone has breastfeeding questions, even at that moment, to feel more like we understand. And thank you for coming and spending the time with us today, and also just for all of your work in leading patient-centered care in this arena. We're very grateful.
Well, thank you for inviting me.
All right, everyone. Have a wonderful weekend, and lots of kudos for you in the chat, Judy. Thank you so much, and have a great day. Bye.
Bye.